So I'll be talking to you about a couple of studies where they've looked at systemic factor control, whether it is the diabetic control, the hyperglycemia, the blood pressure, or the lipid control. Like Dr. Rajiv mentioned, there are currently more than 230 million people, and it's expected to exceed by 350 million by 2025. And in 2003, the five countries with the largest number of diabetics were from India, China, US, Russia, and Japan. And by 2025, the number of people with diabetes is expected to be more than double in Africa, the Eastern Mediterranean, the Middle East, and the Southeast Asia, going on to prove that it is really going to be a huge epidemic in the years to come. For developing countries, especially, there's been a projected increase of 170% of cases, which is very, very significant. And for developed countries, since there's already a lot of lifestyle changes being adopted, the projected rise is expected to be around 42%, and it's the fourth main cause of death in most developed countries. So, diabetes has a very complex pathophysiology, and it's really difficult to explain the whole thing in this forum. But mostly, what we need to remember is both hypoglycemia and hyperlipidemia can lead to oxidative stress and inflammatory cascades, which can cause local activation of cytokines and therefore give rise to inflammation that can lead to nephropathy, retinopathy, and neuropathy. So, you know why these pro inflammatory cytokines are very important now, and they are a target of several of our therapies right now. So, the risk factors are poor blood sugar control, a high blood pressure, and diabetes duration also makes a very important thing. And along with genetics and high cholesterol, smoking, and nephropathy, they are all risk factors for diabetic retinopathy. So, why is glycemic control very important? It's the most important determinant of diabetic microvascular complications. And good glycemic control has had a beneficial effect on microvascular complications, including retinopathy, which we all deal with. So, which were the studies? There have been quite a few of them. We will just look at some of them and their findings here today. So, UKPDS was done for type 2 diabetes and it was set up in the late 1970s by Dr. Robert Turner. It was a multi-center randomized control trial with 7,600 subjects at 23 centers across UK and with a median follow-up of 10 years. The principal questions here are asked: does improved blood glucose control actually reduce the incidence of complications, and do different treatments have any specific advantages or disadvantages? So this was their study design, and the patient characteristics are here. So what were the main study findings are that the intensive glucose control policy maintained a lower HbA1c made it lower by around 0.9% over a median follow-up of 10 years from the diagnosis of type 2 diabetes, with also a reduction of several other risks such as diabetic related microvascular complications, whether it was myocardial infarction, even the need for cataract extraction, retinopathy at 12 years and at albuminuria at 12 years as well, were all reduced risks. So here you can see the difference between the conventional and the intensive therapy, and you see that the HbA1c has been brought down to the upper limit of normal range to 6.2%. And all other diabetes related endpoints also showed a significant risk reduction of 24%. Here you will see diabetes related deaths also decreased. And heart failure also decreased by around 56%. So the progression of retinopathy saw a two-step change here as well, where you can see that the difference between the intensive control and the conventional control, you'll see that the risk has reduced in the yellow column. So deterioration of vision also was much lesser with intensive control, and the urine albumin also showed some response. So basically the UKPDS has shown conclusively that intensive therapy to reduce hypoglycemia does reduce the risk of complications, as well as tight blood pressure control reduces complications as well. But they did not find any major difference between the different therapies that were tested, and the reduction of risk of complications through a very tight or intensive control is quite a realizable goal. So, intensive monitoring and intensive use of existing therapies improved both the blood pressure and the blood glucose control, thereby reducing the risk of diabetic complications. One of the limitations was that the statistical power for subgroup analysis was not very good in this study. Going on to the DCCT and the EDIC for type 1 DM, the diabetes control and complications trial was a major study that happened between 83 and 93. This was funded by the National Institute of Diabetes and Digestive and Kidney Diseases. So this was their study design. So this involved about 1,441 volunteers between 13 to 39 with type 1 diabetes here. Volunteers had to have had diabetes for at least 1 year but no longer than 15 years. The subjects were required to have no or only early signs of diabetic eye disease. So here also they found that the intensive blood glucose control reduced the risk of at least by 76% for developing diabetic retinopathy and the progression of disease by 54%. There was also 50% reduction in the risk of renal diseases and 60% risk of diabetic neurology. So DCCT, this was the intensive control where it has shown clearly that the risk of retinopathy, neuropathy, nephropathy and microalbuminuria all have reduced. So when the DCCT ended in 1993, researchers continued to study more than 90% of the participants in the EDIC trial. This is the Epidemiology of Diabetes Intervention and Complications trial. This basically assessed the incidence and predictors of cardiovascular disease events such as heart attack, stroke and the need for a heart surgery as well as diabetic complications related to the eye, kidney and nerves. This was one of the studies that looked at the macrovascular complications till which time no other study had been done. They also found that the risk was reduced with on long-term follow-up with intensive therapy. So they found a 42% reduction in the risk of any cardiovascular disease event and non-fatal heart attacks, strokes and deaths from cardiovascular diseases showed a 57% reduction of risk. Going on to the ACCORD trial, this was a randomized multicentric trial which was conducted in 77 clinical sites in North America. It was designed to independently test 3 medical strategies to reduce cardiovascular disease in diabetic patients. Here the question was, does a therapeutic strategy targeting systolic blood pressure less than 120 millimeters of mercury reduce the cardiovascular events versus a strategy targeting systolic blood pressure of less than 140 in patients with type 2 at high risk for cardiovascular diseases. So this is how they saw patients. 4,733 patients were seen with a mean follow-up duration of 4.7 years for the primary outcome. There were patients with stable type 2 diabetes for more than 3 months with an A1C of more than 7.5, but less than 9 if they were on more medications and less than 11 on fewer medications. So the age group has been described and also the eligibility for they also looked at hyperlipidemia in this. They had to have an LDL between 60 and 180 with an HDL less than 55. So this is how they saw how the intensive therapy reduced the risk factors. This is the primary and the secondary outcomes on the ACCORD trial. This has been adapted from the publication in NEJM. You can see that the risk of the non-fatal strokes, the non-fatal MIs, cardiovascular deaths and total mortality is all reduced with intensive therapy. So looking at the primary outcome, you can see that the response is almost parallel with both the intensive and the conventional therapy, even for non-fatal strokes. So though there was no significant difference between the two groups in terms of risks for primary outcome or risks of total mortality, the risk for the pre-specified secondary endpoints such as stroke was reduced with intensive therapy. So it went on to prove that intensive therapy does work even for the secondary endpoints. So these are some of the combination lipid therapies that they used. They said that the lipid did not support the use of a combination of fenofibrate and simvastatin compared to simvastatin alone to reduce the CVD events in the majority of patients with type 2 diabetes. Subgroup analysis suggested that heterogeneity in the response to combination therapy by gender or by the presence of significant dyslipidemia requires further investigation. So these were some of the predictions from the VADT trial, which again showed that intensive control is helpful. This is the CURE study. This showed that in type 2 diabetes subjects, duration of the diabetes, the HbA1c, gender, macroalbuminuria and insulin therapy were independent risk factors for severity of DR, and postprandial hyperglycemia indicated a higher risk for DR compared to elevated fasted plasma glucose levels. So this was another study which again showed that a value of 6.5% or less is what they looked at, and the strategy of intensive glucose control involving glycoside and other drugs as required that lowered the glycosylated hemoglobin to a value 6.5% yielded a 10% reduction in major complications. So they've also done a meta-analysis and published it in Lancet 2009, where they've compared most of the studies here and found out which one of them have actually gone on to show that intensive therapy works. So basically the big picture messages here is that in type 1 and type 2 DM, early meticulous glucose control can prevent microvascular and neuropathic complications. And in type 1 DM, early meticulous control appears to prevent CVD in many years later. And in type 2 DM, early meticulous control appears to prevent again both micro and macrovascular diseases in DM. So this is an important thing, that in every 5 seconds, one patient develops diabetes. Every 10 seconds, one person dies of diabetes, and every 30 seconds, a limb is lost to diabetes. So we all know that diabetes is a chronic, debilitating, and an expensive disease which is associated with severe complications, which poses severe risks for families, the states, and actually the entire world. So it's very important that we all push our patients to have more intensive control, refer them to our physicians whenever required, because we may be the first point of contact for many patients who come with diabetic eye disease. Thank you very much.